Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the IMA's Health Matters a Comprehensive Chat, your regular Tuesday night slot, which will be the last one for this year live. And inshallah, we will return again in January just to inform you, but there will be some repeat shows next week. Tonight, we're discussing cancers of the female reproductive system. And once again, we're honored to have Dr. Yusuf Dasoo with us, gynecologist in private practice in Johannesburg. Assalamu alaikum, Yusuf.
Wa alaikum salam.
Alhamdulillah, alhamdulillah, Rabbil Alameen, wal aqibatu lil muttaqeen, as-salatu was-salamu ala ashrafil mursaleen, Sayyidina Muhammadu wa alihi wa ashabihi ajma'een. We're talking about the female today and the condition, which is a very serious condition. But I thought we'll just mention that in Surah Nisa, the 4th surah of the Quran, in the 19th ayah, Allah says we must be kind to our women, and basically referring to women in all conditions. And it's something we must take cognizance of today when we're discussing this. They'll be going through lots of pain, lots of trauma, physical pain, psychological, emotional trauma. When they get these conditions, we must not forget that we need to be supportive of them under all conditions. And while the doctor and the good doctors will always try their best to attend to the physical condition, the symptom, the signs, but we have to be always kind to our women in all conditions, at all times. And I think we should remember that, inshallah.
Sure.
Yusuf, Jazakallah for coming. Cancers of the reproductive system, it's a very, very vast field. I mean, you've got your cervix, vagina, vulva, uterus, fallopian tubes, and the ovary. But obviously, we will then talk of the most common one that occurs. I think that will be, and we'll see how far we can get through, and hopefully the callers will call in with their questions. Cancer of the cervix is obviously the most common. So maybe you can just perhaps touch on what is cancer of the cervix, being the commonest, how common is it? And of course, there's a bit of a differential in the different parts of the world in terms of the wealthy and the poor countries, developed and undeveloped.
Jazakallah, Yakub, for the invitation, and assalamu alaikum to all the viewers. And yeah, as you mentioned, it's a vast topic. And it would be good to start with the most common of the cancers. If we start off with the cancer of the cervix, we see that in South Africa, it's probably the highest incidence of cancer in women. Okay, in the developed world, or in the first world countries, we find that cancer of the breast seems to be higher. And why is there such a discrepancy between the developed world and the developing world? And that's probably because they have a very efficient screening program. Now, we'll come to that. I think it's important to discuss that at some stage. But just to put the viewers at ease, what is cancer of the cervix? Now, we all know what is cancer. Cancer is where cells grow at an uncontrolled rate, and they then start infiltrating different parts of the tissue, and then spreads to different organs, and eventually causes quite severe damage. Now, similarly, if a cancer can occur at any parts of our body, and in the female genital tract, the cervix is the most common area that it affects. What is the cervix? The cervix is that part of the uterus that's protruding into the vaginal area. So we call it the mouth of the uterus, or the mouth of the womb, and that part is the cervix. And that's the area where the most common most common cancer occur in the female genital tract.
Okay, so you're mentioning uterus. For everyone's purposes, that's the womb, which harbors the baby. And the mouth of that particular organ has the highest incidence of cancer. Now, in keeping with all teachings and even prophetic teachings, prevention is definitely better than cure. And this is one cancer of the urogenital tract and the reproductive system of the female, where there is an effective screening program, and the success rate has been proven to be quite good in developed countries if that particular screening program is implemented optimally. What is the screening program? It entails obviously prevention in terms of the most common cause, which is your HPV virus, and you can explain that, and then the pap smear. So I don't know which one you want to touch on first, but those are the two arms of prevention.
Yes, Yakub, you know, it's such a tragedy that in this day and age, we still have such a high incidence of cancer of the cervix because it's a preventable cancer. It's a cancer that if it's picked up early, it can be treated quite effectively with a very, very good outcome. And not only if it's picked up early, in addition, it has a precancerous stage that can be picked up. And that's where you touched on, is there any effective screening methods to detect cancer of the cervix? Yes, there's very, very effective screening methods. If we look at the literature, there are countries in the Scandinavian areas that have such an effective screening program that their incidence has gone dramatically down. And so there's no doubt that an effective screening program will decrease the incidence of cervical cancer very, very dramatically. And in addition, you will probably pick up the cervical cancer at such an early stage that the prognosis is almost 100% cure rate. Now, unfortunately, in our country, it's not that. We have a very, very poor screening program. Many people don't make use of the screening program for various reasons. Economy, socioeconomic status, the vicinity where, or the distance to where clinics offer these services. So there's many reasons why maybe in South Africa the screening program is not effective. But let's talk about the screening program. This effectively in the
pap smear.
The pap smear, okay, the pap smear. It's named after a Greek doctor called Papanikolaou, George Papanikolaou, and he invented this smear. And it's such a simple test. What is this pap smear? A pap smear is taking cells that are being shed out in the area of the cervix, and it's usually combined with a bit of mucus. So one takes a sample brush and just turn the brush and tries and gather some of these cells, and then it's either spread on a slide or it's put in a medium and then sent off to a laboratory. And these cells are then seen under a microscope and studied, and will then be seen as either normal cells or abnormal cells. And a report will then be given to the doctor, and then he'll then relate to a patient to say, look, everything is fine, you don't have to worry, you come back for another pap smear. Or he'll tell you, no, I'm a little bit worried because there's some abnormal cells and we need to act on it. So yes, a pap smear is a very, very effective screening program. The viewers may want to know, how often do you screen?
That's very important because that has changed.
Yes.
It used to be every year, the recommendation.
Correct.
But before you get to that, I mean, you mentioned cost, right? The actual test is not that expensive. It's more the access to the particular test that you're referring to. So those who have access to the test, in itself, it's not that expensive.
Correct. I mean, if we're looking at tests that are available in the public sector, there's no cost to it.
Yeah.
Okay, it's been
even
offered.
in the private sector.
But in the private sector, it's also a very, I mean, it costs, most laboratories charge between 100 and 200 Rand maximum.
It's under 200.
Yeah, it's under 200 Rand. So it's not a very, very costly exercise.
Yeah.
Now, we mentioned also a little bit about the different types of pap smears, or the ways
new
they can
technology
be. Yes,
now,
there's
right?
new technology. Initially, what we were doing is taking the slide, taking the specimen and spraying it onto a slide. And today we use something called liquid-based cytology. And you take the same cells that you've collected and put it in a certain medium, and then this medium is spun down, and your pickup rate of abnormal cells become much better. So that's the advantage. The advantage is that your pickup rate becomes better, it becomes a more effective screening program, and in addition, if one needs to do additional tests in that liquid, you don't need to call the patient back.
Yeah.
You can do the test on the same
Specimen.
specimen.
Yeah.
Now,
okay, so now the frequency of the test.
Yeah.
Okay, there's going to be different grades that you will find once, if there is an abnormality. The more common ones are the squamous carcinomas, and the other one is adenoma. But that's technical, that the doctor will discuss with the patient in the different categories. But the frequency, the recommendation, what is the current recommendation?
Okay. So it also depends on which country you're living in, and in our country, due to the limited funds available in the public sector, their screening program has been allowable screening is actually 10 years.
Okay.
Okay, and that for us is a very, very large gap
big window
from one screening time to another.
Mm.
They've done that so that they could accommodate a lot more screening. Most countries recommend that screening should be done every 3 years. Okay, so most countries recommend if you're in the age group between 20 and 40, you can do it every 3 years. After 40 or after 50, because the incidence starts dropping, you may want to extend that period of screening. Now, there are some instances that has been reported in the literature where if you do a pap smear today, and if you repeat one in 2 years' time, or in a year's time, they have found some abnormality within that year. But that's not the norm. That's not the norm.
Okay, we'll continue the discussion. The lines will be thrown open very shortly and the number will appear at the bottom of your screen. So we'll take the ad break and then we will meet you again shortly. Assalamu alaikum wa rahmatullah. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat from the Islamic Medical Association. We got Dr. Yusuf Dasoo tonight. We'll be discussing cancers of the female reproductive system. And the lines will be opened shortly for your calls on 011 086 7700 1, 2 or 3. And the number is at the bottom of your screen. Yusuf, we were discussing the pap smear and the frequency, but that is now a general rule for most people. But there are others who have a higher risk of getting this particular cancer because they are prone to the risk factors. So then they will need to get the screening test done more frequently. So in that context, what are the risk factors for cervical cancer?
Yeah, Yakub, I totally agree with you that that the general screening is probably about 3 years. That's an acceptable frequency. But if you have a high risk, you should probably have it done every year. Now, what are these risk factors? If we're looking at what is the actual cause of cancer of the cervix, 99% of the time, there's an associated virus that affects the cells, changes the cellular content of the cells, and then allows it to become malignant. Okay, and
so that's a definite cause. It's not a risk factor.
That's a definite cause, right? That's a definite cause.
Okay.
And that virus is called the human papillomavirus.
Okay.
Now, if you've been previously exposed to that virus, you then obviously have the higher risk factor to that. So we know that it's a direct cause, that in almost all squamous cell carcinomas of the cervix,
which is the more common one.
The most common one.
Right.
The causative factor is a virus called the human papillomavirus. Now, this is a similar virus that also causes warts. You know, the simple warts, and that would be the one important factor to remember. If you've been exposed to that, rather have it annually. But there are lots of other risk factors or co-contributors
over and above the human
papillomavirus that may be associated with this increased incidence of cancer of the cervix. The one that's been implicated quite often is smoking.
Right.
We find that patients that have developed cancer of the cervix, a large number of them have been smokers. Okay, as opposed to the non-smoking population. Another risk factor is immune suppression, either by conditions such as HIV, where HIV causes immune suppression in your body, or medication that patients are taking that is causing immunosuppression. And how does that work is that once your immunity is suppressed, you can't fight the virus. Normally, a body will be able to fight a virus on its own before it becomes a problem. So your inability to fight the virus will then cause the virus to then attack the cells and cause the cancer of the cervix. Obviously associated with that is patients that have had recurrent infections. And the most common is your things like your chlamydia and your other STIs.
So those are sexually transmitted infections.
The sexually transmitted infections. So if you have a recurrence of sexually transmitted infections, or you have been exposed to many of these infections, you tend to have a higher risk of developing cancer of the cervix. Now, is it the infection that's causing it? Or is it the fact that maybe you are having multiple sexual partners, which is another independent risk factor that may be associated with? So these are the common risk factors. There are other factors that have been implicated, like such as the parity, which is the number of babies you have, family history, prevalence in a certain community, but generally by far that's the highest.
So these are generally all avoidable.
Yes, I think most of them are. I mean, family history is unavoidable.
No, but the earlier ones you mentioned.
But of course, those are all avoidable. You use condoms, you have single Islam teaches us that. You know, simple things like have one partner, have sex only after marriage, you know, all those things, personal hygiene, don't smoke, you know, all those type of things would then decrease your risk of developing cervical.
Of course, we're talking one partner within a marital context, so you can have more than that, but are they again within the institution of nikah, and then you will be avoiding a lot of problems amongst many other things. You'll be avoiding cancer of the cervix, inshallah. But now this human papilloma virus, for ease of speech here, we'll just call it HPV, it's commonly known. There's an advocacy now, obviously, with the vaccine that is available. You get, obviously, different strains. So, and then those that are got the low risk and then the high risk, and they've been numbered. So perhaps the low risk are the 6 and 11, and the high risk are the 16 and 18. So your vaccine that's available, it's targeting those particular types. Is that correct?
Yeah, that's correct. So what you're talking about is this vaccine, can it prevent cervical cancer? Right? We're talking about, we mentioned the first factor, how can we prevent cervical cancer? The one is to avoid the risk factors. The two is to have regular screening programs like your pap smear. And lastly would be a vaccination like what you've just mentioned now. Now, this, you mentioned a few subtypes of the HPV. There's in fact probably over 150 subtypes.
These are the more common ones, right?
These are the most common ones, right? Now, because there's so many, we mentioned 6 and 11 simply because it's the more common one. You mentioned 16 and 18, probably 31, 33. If you take 16, 18, 31, 33 and group that together, it probably accounts for maybe 90% of all the high-risk viruses, right? Whereas your 6 and 11 will probably account for maybe 70 or 80% of the low-risk viruses. Now, what do we mean by that? We simply mean that the low-risk virus usually causes genital warts, right? And they are less likely to affect the changes in the cervix that eventually becomes cancer of the cervix.
They're more easily treatable.
Yeah, they're more easily treatable. Whereas your high-risk viruses are more likely to cause changes in the cervix that will eventually form cancer of the cervix. So they made it easier now for us to understand. High risk is something that you need to be more aggressive with your treatment. Low risk, you can be more conservative with your treatment.
And that aggressiveness in terms of attacking this problem, we have a vaccine available. So in what age groups do you give the vaccine? And do you only give the vaccine to the female? Because this is a contact disease. So obviously, you should be giving to the male too.
I think, you know, you've touched a very, very important point, that where does the virus start from? It actually starts from sexual contact and usually directed from the male to the female, usually directed. And are we targeting the right population? And a lot of literature is now coming out that you should not only vaccinate the female, you should start vaccinating the males. And in some countries, they've already started implementing the program of male vaccinations. The problem is, the limiting factor is obviously the cost of the vaccine. And we'll then talk about now the different type of screening and at what age group that we're going to do.
The lines are open and the number is at the bottom of the screen, so please do call in. While we're discussing here, we would really, really like to take your calls, and Dr. Dasoo is prepared to answer your questions as best as possible, inshallah. It's a very interesting topic, so please do call in, inshallah. So the vaccines, what age group? Let's now, what most common practice now in this country at the moment, now in the context of South Africa, we are looking at generally, we've targeted the females, right? What is the optimal age where this vaccine must be given? And there are about 2 types, I think, in the marketplace, right?
Correct. So the optimal age is before exposure to the virus. Okay. So when are you exposed to the virus? Usually at the time of sexual contact. Okay. So before the first sexual contact, you should actually be vaccinated. Okay. Now, even if you have not taken the virus after your first sexual contact, you'll still benefit from that, from the vaccine. So it's advocated in South Africa from the age of 9 years to the age of 29. Okay, so it's from the age of 9 years, a young girl from the age of 9 to 29. In some countries, they're going up to the age of 40, and has been found also to be quite effective.
Some beneficial.
So so that's ideal. The Department of Health has just embarked on a program. As I mentioned, the limiting factor probably is the cost of the vaccine.
It's expensive vaccine.
So it's an expensive. So they can't go and vaccinate all the people in our country at the moment, and it's not affordable. What they're doing right now is targeting 11-year-old young girls, and they've started a vaccination program for every 11-year-old girl in the public hospital situation.
Which is a very reasonable program to start.
I think it's very reasonable. It's a starting point, and eventually that will have the flow of the benefits maybe in the next 5 or 10 years' time.
Inshallah. We'll take another ad break, and we'll see you after the ad break, so please do call in. The number is going to appear again at the bottom of your screen, so we'll be seeing you again shortly, inshallah. Assalamu alaikum. Welcome back. Assalamu alaikum wa rahmatullah. The Health Matters IMA comprehensive chat, cancers of the female reproductive track, and we're waiting for your calls. We've been discussing cancer of the cervix, recognition in terms of the screening program, and prevention as the vaccines. Phone numbers are going to appear at the bottom of your screen again, 011 086 7700, or 1 or 2 or 3. Please do call in. We have Dr. Yusuf Dasoo here with us. Yusuf, we're discussing, we got to the point of vaccines, 2 vaccines available in the market against the HPV, one of the preventable cancers that we know of. Any further comments on the vaccines?
Yeah, they're basically both as effective in preventing cancer of the cervix. Okay. The one is the bivalent vaccine, the other one is the quadrivalent vaccine, simply meaning that the one is effective against 2 of the subtypes, the other one is 4 of the subtypes, but of those 4, 2 are the low risk. Yeah. So from a point of view of preventing cervical cancer, they're both equally effective. In fact, although they only have 2 subtypes, they are effective against other subtypes as well. So, for instance, the Cervarix vaccine is the 16 and 18 vaccine, but it's very effective against 31 and 33 as well. Okay. So there's a lot of cross protection of the vaccine. As opposed to the other vaccine, Gardasil, in addition to the protection of cancer of the cervix, it also helps decrease the chances of getting genital warts. Okay. So that's the difference between the two. The way it has to be given is that it has to be given in a regime of 3 vaccines, and usually given over a 6-month period.
Okay. And that obviously you can discuss with your doctor and book in advance, and then you'll do the program and try and stick to that particular regimen. Otherwise you'll lose the efficacy. So we've got a caller now. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum. Okay, please do call in with your questions. I think we lost you there. Please try again. Yusuf, so obviously we got a precancerous stage which we've been talking about, but then there's a stage where the disease is starting to develop. So it'll have some kind of signs, symptoms, some indication. What would be those?
Okay, yeah. So if somebody has already got cancer of the cervix, the signs and symptoms would be abnormal vaginal bleeding. That would be probably the most common presenting symptom. So if somebody comes in, they have a normal menstrual cycle, and all of a sudden their cycle changes. Either they're getting bleeding between their periods, or bleeding throughout the month, or very heavy bleeding, or spotting throughout the month. So any abnormal change that's persistent would then be one of the symptoms that they present with. Another very common symptom is bleeding after intercourse, because these tumors are very vascular. Any contact with them will cause bleeding. So that would be another common symptom. And another symptom would be an offensive vaginal discharge that, despite treating with antibiotics, it just doesn't get better. So recurrent vaginal discharges may also be a presenting symptom of the cervical cancer. That's early stages of presentation.
So at that point, do you still go ahead and do a pap smear, or you do more than that?
Okay, so in that particular case where you see an
got a suspicion.
if you have a suspicion, and if you examine with a speculum and you visualize the cervix, and if it's overtly malignant, in other words, it looks abnormal, then you wouldn't do a pap smear.
Okay.
Then the treatment of choice would be to do a biopsy to confirm your suspicion. Then if that comes back as positive for the diagnosis of cancer of the cervix, you'll then need to stage it, and then according to the staging give the appropriate type of therapy.
Okay, so once you've diagnosed it, you've done the biopsy, and you've got different grades, what then?
Okay, so there's essentially the treatment can be divided essentially into two different treatment modalities. The very, very early stage of cancer of the cervix can be effectively treated with surgery. Okay, the type of surgery is an extended hysterectomy, where not only do you remove the uterus, the cervix, a little bit of the vagina, but you want to remove some of the lymph nodes as well. And that's quite effective in the early stages of the disease. But once it goes beyond the early stages, you're going to the later stage, then surgery is not very effective, and you'd require radiotherapy as a mode of treatment.
Later stages, meaning that the cancer spread within the reproductive system or beyond? What do you mean?
Yes, later stages would mean within and beyond.
Okay.
So even if it's within the reproductive system, it's still regarded as quite a severe
Advanced.
spread, because it has an ability to spread up to the bladder, down to the rectum, or on the side walls. So even though it hasn't spread far, it's still a very severe form, and would not benefit from surgical form of therapy.
Okay. So then you would do radiotherapy and chemotherapy.
Yeah, some people have only some people are only treated with radiotherapy, and that's the primary modality of treatment. But often they are treated with chemotherapy and radiotherapy as a combination of the two. And depending obviously on the staging, your survival rate will really depend on how severe the condition is.
Yeah. And how far you've gone with your treatment.
Correct.
The lines are open. Number is 08011 086 7700 1 or 2 or 3. We're discussing cancers of the female reproductive system. We've been talking mainly about the most common cancer in that particular area, the cancer of the cervix. And Yusuf, I just want to bring something else in. So those that you detect early, is there some sort of fertility preservation that they can still fall pregnant?
Yeah, that's a very difficult question to answer, Yakub. It depends really on the staging. If you have cancer of the cervix, you need to destroy that cancer, and that cancer is part of the uterus. And the uterus is what holds the baby.
Organ, yeah.
So often any type of therapy would be destructive or removal. So in other words, surgery would mean removal of the entire uterus, or radiotherapy and chemotherapy would be to destroy tissue that's close to the uterus. But from an Islamic point of view, it may be a problem. From other points of view, yes, fertility can be preserved. And the way it can be preserved is that either the ovary can be removed and frozen, or the ovary can be relocated to a different area out of the field of radiotherapy.
Okay.
Or thirdly, you could stimulate the ovary, produce oocytes, that means small little eggs, and aspirate them, remove them, and freeze these eggs in the stimulated stage for later conception. In other words, those eggs can be utilized and combined with the husband's sperm, and embryo can be formed. But now you've got an embryo without a uterus.
Yeah.
So your only option would then be surrogacy.
Okay.
Okay.
So we have an ethical problem there, but it's being done, but there's an Islamic restriction on that.
Correct. But obviously, Yakub, when we say early stages, we're talking about established cancer.
Yes.
Right?
Yes.
There's obviously the pre-cancerous stage,
which is obviously a stage where you can deal with more effectively.
Correct. And that's where you can preserve fertility. You can save patients from becoming full-blown cancer, and depending on that stage as well, you have stage 1, 2, 3, or SIL low grade and high grade. There's different ways of calling a precancerous lesion. I think we must discuss that.
Let's take the ad break,
okay,
and then we'll come back. Assalamu alaikum. We'll see you shortly.
Okay.
Comprehensive chat by the Islamic Medical Association. We're discussing cancers of the female reproductive system. We've just got through, or barely got through, the most common one, cancer of the cervix. We were discussing, obviously, the main focus is to prevent this disease. So again, I think we probably can take a step back again and say, when an abnormal pap smear is presented to you, what do you do?
So an abnormal pap smear is a screening test.
Yeah.
In other words, we can't make a proper diagnosis that there is a problem.
Yeah.
It's telling us to suspect that there's a problem, indicating that there may be a problem. In fact, an abnormal pap smear can come back as either atypical cells, or they may suspect a high-grade lesion, or they may suspect a low-grade lesion. So that's the way that we would normally read a pap smear for any abnormal result. So if it's normal, we're very happy. If it's abnormal, and obviously if it's cancer, it's a bit too late. That means our prevention hadn't worked in that particular person.
The disease is there.
The disease is there already. Now, if we have that, it may come back that despite them finding an abnormal cell, it may be normal. Because we sometimes can overdiagnose, and that's why
called a false positive.
A falsely positive result, right? Okay. And that's because the cells are seen with the naked eye, and there's just loose cells, and there's not a tissue diagnosis. So you need a proper tissue diagnosis to make to treat the patient effectively. Now, what if we find an abnormal pap smear? The first thing to do is to find out. In today's time, the first thing to do is to see what type of HPV virus is present in that particular individual, right? So we do HPV testing of the virus. So this, as I mentioned before, when you're doing a pap smear, you can do it through something called a liquid-based cytology. That same fluid can be used, and the DNA of the HPV virus will still be in that fluid, and the test will be done to detect what type of DNA it is, and then subtype it.
How does that help you?
Okay, so that helps us quite a lot, because if it comes back as a low-risk virus present, and there are some abnormal cells, you may not need to treat immediately.
Okay.
So you call the patient back in 6 months' time and say, look here, most likely this abnormal cells will get better. So the body has a good way of repairing the tissue, and it may get better. You call them back in 6 months, and if that abnormality is gone, well and good. You don't have to worry, except do annual pap smears after that.
So you guys are comfortable with this 6-month period?
Correct. 6 months period. Some
with the low risk one?
With the low risk. As long as you've got a low risk HPV, you are fine. There's no chance that a cancer will be present. Okay. The problem comes in if the HPV has been detected as a high-risk virus, because now this would mean that this abnormality that may be present can be precancerous.
Okay.
So they would require further assessment and treatment.
Which is?
Right. Now, as I mentioned, we've just got a cellular diagnosis. We need a tissue diagnosis. So what we would then take the patient for is something called a colposcopy. Okay, what is a colposcopy? Is we visualize the cervix, the mouth of the uterus, under a high magnification. We use some fluid that will enhance abnormal tissue and abnormal cells, and those pieces of tissue will then be biopsied.
Okay.
Now, there's two types of treatment that we could do, either a one-step treatment or a two-step treatment. Most of the time we do a one-step treatment today. The two-step treatment would mean a patient coming back the second time. I'll first discuss the two-step treatment, which would mean once we've visualized the abnormality, we need to biopsy it, send it to a laboratory. If it's confirmed the diagnosis that we've suspected of abnormal cells, we'll then need to go and treat it. And we'll discuss the appropriate treatment for that. Or you could do a one-step diagnosis and treatment together.
All in one.
All in one, okay? And that's under microscope guidance again. You insert the fluid that will enhance the abnormal cells, and then you do a procedure called a LETZ procedure, okay? L-E-T-Z, which stands for large loop excision of the transformation zone. It's just a big medical term for saying we need to excise enough abnormal tissue that we can see and then send it to a laboratory for testing. Now, what is that advantage? It's a one-step test. You won't lose people from follow-up and treatment. And despite having, in addition to having tissue, it can be totally therapeutic. Okay, so that's the advantage. So what is this large loop excision of the transformation zone? Is actually removing any abnormal tissue that you can see under microscopic guidance. So
the one-step and two-step, that decision is based on?
Okay, the decision is based on the individual. So it depends on each one's circumstances, the type of patient you're dealing with. If you think a patient is going to be able to come back and you won't be lost to treatment, so what happens normally in the public sector is that you have a screening program that's not totally effective. You know, it's done every 10 years. You then get a patient that comes in and you tell them, and you find an abnormal pap smear. A lot of those abnormal pap smears, you won't find the patient and you won't trace them. So those will be lost to follow up. So that's the first loss to follow up. The second loss to follow up, you call them back, you tell them that there's an abnormal pap smear, and then you take a biopsy and then tell them to come back a month later. There's a fair percentage of those patients that won't come back. So again, lost to follow up. So the advantage of doing it once and for all is that both diagnostic and therapeutic. So it depends on the patient that you're dealing with, and your individual preferences, but that would be the treatment. So yes, it's not only diagnostic, it's therapeutic. But you've got to advise the patient that, and once you obviously wait for the result, it comes back and it's confirmed the abnormal cells, you've got to make sure that your result comes back, that the entire transformation zone or the abnormality has been removed, and you haven't left anything behind. However, it's important to remember that this is a conservative form of treatment because you're preserving the uterus. You're only taking the abnormal cells. And therefore, there is a chance of recurrence, and patients will still have to come back for regular pap smears and follow-up.
Okay, we almost run out of time, and it's a big topic. We didn't even get to the other ones, the more other common ones also, not as common as CA cervix, but the uterine cancers, and then again the ovarian, and then of course the less common ones. But hopefully we will touch on that in the future. But before I wrap up, Yusuf, your advice, your take-home message for tonight. Regular screening.
I think the one important thing is we have the opportunity of a disease that's common and can be prevented. So please go for regular pap smears. You'll be able to pick up an abnormality. All the young ladies should have the vaccine. It's a very effective method of prevention. So there's no doubt we can treat a condition effectively. Don't ignore it. Go and seek help.
Okay, Jazakallah khair, and we really appreciate your advice and the education you've given us again. It's our last show for this particular year. There will be some repeat shows over the holiday period. We will be returning, inshallah, again in January with live shows. And I just want to give some advice again that while we're traveling, we wish you from the Islamic Medical Association a healthy holiday. And not to forget that while you're on holiday, your du'as are, and while you're traveling, your du'as are accepted. So please pray for all those that are in suffering, not only in this country, but all over the world, and all those that are ill, and yourself also. Don't forget to read your du'as for travel and seek Allah's guidance while you're traveling, and maintain a good health while you're going. Assalamu alaikum wa rahmatullahi wa barakatuh from the Islamic Medical Association Health Matters, a comprehensive chat for 2014.